Morning. First case is a 13-year-old male, status post fall from a ledge with a right talus avulsion fracture and a left medial malleolus fracture. There were closed injuries. He was neurovascularly intact. This is the right side and the left side showing the medial malleolus fracture. The right side was made, weight bearing is tolerated in a cam boot, and the left side was placed into a cast that was bivalved, made non-weight bearing. This is a 65-year-old female, status post fall with a left non-displaced tibial plateau fracture. She was neurovascularly intact. Of note, she had a recent cabbage. She has a history of lymphoma and breast cancer. She was placed into a bulky knee immobilizer and made non-weight bearing.
Good morning. First patient is an 11-year-old male presenting after a fall. This right distal radius shaft fracture. She was neurovascularly intact, closed reduced, placed into a supracondylar splint. Next patient, the 77-year-old female, presented after a fall. This left distal radius fracture. She initially was seen by her PCP and sent for x-rays. Patient presented to the office a couple weeks later. Repeat radiographs are shown, and the patient was taken to the operating room for open reduction internal fixation.
There was no attempt at a closed reduction?
So she presented about a little bit over 2 weeks to the office. And this is what those x-rays looked like at that time. So I think just given her age and the fact that it was pretty significantly angulated, the decision was just made to take her to the operating room.
How was she doing?
What was that? I'm sorry.
How was she doing in the office? Like, she was 2 weeks out from the injury. She has it displaced. I'm just curious, what was her condition like? Was she complaining? Did it just look funny?
Yeah, so I personally didn't see her in the office when she came in, but preoperatively,
she was fine. I mean, she really didn't have a whole lot of pain. She didn't have there were no dysesthesias or paresthesias. She had a deformed wrist, but she was actually doing fine. I fixed her anyway.
So Dan, just talk about that plate and what are the potential problems with the plate as it is right there?
So I guess intraoperatively, one of our concerns was, the relation of the plate to the watershed line distally. We felt that it was, far enough from the watershed line where it wouldn't really cause any issues, with her flexor tendons, or wouldn't cause any impingement into the joint. We had good radiographs and good range of motion, where we were able to confirm that there was no involvement of the joint.
Well, I think you're past the watershed line, and I think you had to do that just because of how distal that fracture was, and that's why that plate gives you a variable angle, and you did a great job of getting that below the articular surface. But yes, that's a risk on the volar side. What about on the dorsal side with your more proximal screws? What if there is going to be a problem? What do you expect there?
Yeah, I mean, they could be, they might be a little bit long on the longer side. There could be some irritation, of the extensor tendons, but it's definitely something to keep an eye out for and to counsel the patient. If she's having any difficulty or irritation, especially with extension of her fingers and flexion of her fingers in this case.
That's more of a problem distally with the, with the metaphyseal screws. And I agree the screws are a little bit long, but usually they tend to be, you tend to run into problems with EPL going around listers.
And can you show where the watershed line is with a mouse?
So it's usually we kind of use like pronator quadratus as.
Gotta put your mouse on the screen. Right.
We usually use like pronator quadratus as a indicator of where the watershed line is. So we're kind of like right at the watershed line.
Well, you really can't go any more distal, and that's a Sang type 2. That's at the watershed and below a line parallel to the volar cortex. That's at the tip of that distal radius. mean, you have the reduction, nice, but I think Brian's getting at is plate placement is very important, so you don't have to worry about taking it out or having tendon problems.
Thank you.
Dan, what's the AAOS recommendation for 65 plus patients with distal radius fractures?
So I think outcomes actually show that, you know, between operative and non-operative management, outcomes can be pretty similar. Given we have an appropriate reduction and maintenance of reduction in those patients.
So yeah, I don't think this is the patient that they're talking about, but the recommendation is moderate against fixation. This is not that patient. And at 2 weeks out, you know, the choices are live with it or do surgery. You're not gonna do a closed reduction of this patient in the office. So, but this is a patient that if they had an acute closed reduction wouldn't need surgery. And that's just, you know, you see this kind of stuff. This is what you guys do in the ER, you know, saves the patient the surgery, and this patient needed surgery.
I agree with everything except for that last comment. They didn't need surgery. I think it was a good idea, but I just saw Swan like this and I just said, leave it alone. It was clinically healed at 3 weeks. They had no pain. And I said, if it's a problem, I'll do an osteotomy. So, I mean, you can leave these alone in a 75, 80-year-old person, and half of them or more won't come back and won't complain.
I agree with that. And you know, again, this is my patient. I decided to fix it for a couple of reasons. One was she's, you know, you always talk about activity levels. She's pretty active, all things considered. And I really don't like when the carpus is that far, you know, displaced, either whether it's dorsally or palmally, because I do think that they can change still at she's only 2 weeks. That could have gotten worse, you know, given a little bit more time. So for those reasons, I fixed her. If she was, you know, a little bit more frail, a little older, I think, you know, David's absolutely right. These do fine. She was fine. She was okay. And, you know, she was like, really have to fix it? And I was like, well, we don't have to, but I think it's a good choice for you.
Yeah, I mean, I take that back. I mean, need surgery is not true, but you need to read the patient, the riot act about what's going to happen to them. And they're going to have a lot of limitations with pronosupination probably. And they're not going to be able to flex their wrist at all. So if the patient's okay with that, then certainly you could do an osteotomy later.
Yeah, Tim said it correctly. And just so you know, because I mean, I know a lot of people don't treat these closed. It's surprising how good their motion is 6 months or a year later, leaving it like this. And again, I'm not promoting that, and I agree with what was done, but the motion isn't terrible. And for some reason, the pronation supination isn't terrible. And it's interesting. I mean, obviously not good in a young person. They'll develop mid-carpal arthritis and they'll have all kinds of problems, but the older people tend to tolerate this. If you happen to see it at 4 weeks or 6 weeks and you want to do nothing, it's not the worst idea.
Next patient is an 81-year-old male presenting after a Goliath fall, right femoral neck fracture. Patient was taken to the operating room for right hip arthroplasty. Thank you.
Good morning, everyone. First, we have a right-hand dominant 8-year-old male, status postgranular fall, this left distal radius fracture, shaft fracture. He's closed reduced, placed into a sugar tongue splint. Next, we have a 14-year-old male, right-hand dominant, status postgranular fall, this left long finger metacarpal shaft fracture. He was placed into AP slabs. Next, we have a right-hand dominant 6-year-old female, status postgranular fall, this left shoulder fracture dislocation, greater tuberosity fracture dislocation. She was closed reduced, placed into a sling. She'll follow up in the office for discussion of surgical management. Next, we have a right-hand dominant.
Are you recommending surgery for that, Jomar?
Yeah, so, you know, I don't think it's cut and dry. I'm, you know, measuring this, just 4.8 millimeters. off with the tuberosity sort of just below what we consider is the acceptable amount. There's a good study about delayed migration of these fractures, these greater tuberosity fractures. They tend to migrate more when they're associated with fracture dislocations. It was a study in the Journal of Orthopedic Trauma in 2005, and they found that probably 15% of their the greater tuberosity fractures that were associated with dislocations ended up migrating. And
So you could
displacing
keep a close eye on this, but would you accept this as a final reduction if it healed like this?
I think it would be okay if the patient was functionally. Yes. Next is a right-hand dominant 96-year-old female, southwest ground fall with this right proximal humerus fracture, greater tuberosity fracture as well. She was neurovascular intact and she was not dislocated. She was given a sling. She'll follow up in the office as well.
Is that just a greater tuberosity fracture?
No, it's not. Also surgical now.
So from a rating,
And what else?
The greater tuberosity is displaced.
And the other side of it, anteriorly?
The humeral head,
And what else?
sir.
The lesser is off too. You can see it on the axillary that you have. So it's probably a 4-part.
Next is a right-hand dominant 53-year-old female, southwest ground fall with this left distal radius fracture. She's closed reduced, placed into a sugar-tonic splint. Next is a 45-year-old male who punched a plastic table repeatedly, sustained this right 5th metacarpal base fracture. It's placed into this ulnar gutter splint. Next is a 53-year-old female, southwest ground level fall, this left tibial plateau fracture. She's placed into side slab immobilization. And she'll follow up she's made non-weight and she'll follow up in the office.
Good plan.
Yeah, so for right now, I think for her, our plan is tentatively non-operative. She had pre-existing degenerative joint disease. She was about 4.6 millimeters of articular step off. She didn't really have that much widening. And so I think that we can probably trial, see where she is in the office in about a week. Once the swelling has gone down, we can do a better ligamentous exam and see if she has a stable knee. I think that would be appropriate to trial non-operative management for her.
So if she comes to the office and she opens to valgus, do you think she has an MCL sprain or an MCL tear that's causing her valgus instability or valgus laxity?
No, I think perhaps it's more just that the lateral condyles falling into that depression.
That's a big part of deciding whether to manage it operatively or non-operatively, right? If valgus are in the office,
Yeah.
if she opens a lot, she might not do as well non-operatively as if she's relatively stable.
There was a few studies I looked at. There were some that described up to 3 millimeters of depression. I was studying 94 by the Honoken Clinic, I think, and they just talked about articular step off 3 millimeters, widening of 5 millimeters, and as Dr. Gatt mentioned, valgus 5 degree, and then severe instability being the things that would cause poorer outcomes in their patients.
Is this patient healthy?
Yeah, it's a healthy young woman. I mean, so history of diabetes well controlled, hypertension well controlled. No structural heart disease, no history of any severe vascular accidents.
So the original paper was a centimeter depression. That was a guy named Nichols. And what he would do is bring every one of these plateaus to the operating room, and under X-ray, he would stress them. And if they were stable, because they had a stable rim. Didn't matter how much depression there was. You know, you would treat them non-operatively, and they all had equal outcomes to the ones that were operated on. So, you know, that's the idea of you can get a stress X-ray or standing X-ray in the office. If they fall into that divot, then they're not going to do well.
But that stress view is in what position of the knee, Jomar?
It's an extension.
And if you're testing the MCL, what position are you in?
30 degrees.
Yeah, exactly.
Thank you, guys.
Good morning. First patient is a 32-year-old male, status post punching a tree with left, fourth, and fifth metacarpal dislocation, metacarpal-based dislocations. He was initially closed reduced and placed into AP slab splints. CT scan was obtained, showing he had a good reduction at that time. He then returned to clinic 10 days later. He had taken his splint off the day before because it was uncomfortable. He got repeat radiographs that next day, which was about 10 days out, still had maintenance of reduction. He was placed into a short arm cast. It went up to immobilize the MCP joints on the fourth and fifth digits. Next patient is a 19.
Did you need a CT scan to confirm that he was reduced?
What was that?
Did you need a CT
at
scan?
10 days? We didn't
No.
repeat it.
No. Did you need the CT scan in the first place?
No. No, probably not. I mean, they talk about a 40-degree supinated view, can tell you for sure if it's reduced. We probably could have gotten away without that CT scan.
So what would be a reason to have a CT scan of that injury?
To look for associated fractures. And there was just kind of like some avulsion off of likely the hamate.
Yeah, I mean, there's some that are more obvious than others that need to be fixed, and a CT scan can help you. This one was probably one you didn't need it.
The position of your cast, the best position for hold out reduction?
The initial.
No, right. The one you sent him out in the cast. He's in pretty neutral position. Is that what you want?
He probably could have been in a more flex position.
Flexion.
More flexed, more wrist flexion?
Yeah, wrist flexion.
Polar flexion or dorsiflexion?
Dorsiflexion.
I think that would help. My limited knowledge.
Next is a
What happened to the tree?
The tree. There's a longitudinal split in the tree. It was taken down by an arborist the next day.
Probably the deer got away.
So what was the deforming force on that fifth metacarpal?
ECU.
Okay, so it should make very clear sense that it's dorsiflexion.
Next patient is a 19-year-old male, status post soccer injury with a left trimal ankle fracture. He presented initially 4 days after his soccer injury, was extremely swollen, was initially closed reduced, placed into a short Aaos splint. He then it was bizarre, but he was extremely swollen. We initially X-fixed him. He no-showed to clinic the next week, but then did show up the week after that. So he was about 2.5 weeks out or so from this injury, and we were able to take him back for left ankle ORIF. He did have some comminution and some bone loss anterior medially.
So did you fix it? You
We
said it
didn't-
had common anterior medial.
That's the bone loss is what he's asking.
We did not graft or we did not place any graft or do anything there. We tried to get as good of a reduction as we could. We didn't place any graft.
What about potentially fixing the posterior mount? Any
we thought-
consideration to that?
What was that?
Fixing the posterior malleolus, any consideration to that?
Yeah, there was consideration to it. Based off of the percent of the joint, we kind of elected to just address everything laterally. We didn't go posteriorly on this. We thought he was like under 20% posterior mouthpiece, so we thought it would be stable if we were able to just address things laterally.
Are there other considerations other than the size of the posterior malleolus? Does it contribute to any stability of the ankle?
Yeah. Posterior inferior tibiofibular ligament attaches there, so yeah, it does contribute to the stability of the ankle joint. So if you get a good reduction of that posterior mouthpiece, you can fix the syndesmosis well. We elected to fix it with a syndesmosis screw, but we could have very well went posteriorly as well.
How strong? What kind of plate do you have on the fibula?
It's a 1/3 tubular plate.
Is it pretty flexible, especially if it's such a long plate with a big gap in between where the fixation is?
What was the question? Was it?
Yeah, it's pretty flexible.
It is flexible, yes.
So when you fix the fibula before you put the syndesmotic screw, did you stress it then?
Yeah, we did stress it. Unfortunately, the X-rays weren't saved on this one. The stress.
Let me guess, it opened up a lot.
It did open up quite a bit.
Why do you think that is?
It's because that posterior mouthpiece was off.
And your plate is very flexible. So even if the posterior mal was fixed and you externally rotate with such a long thin plate, it'll probably still open up to some degree. You might, when it's such a long, although there's lag screws in there, it gives you a little more fixation, but especially when they're high Weber C and comminuted, you might want to consider a stronger plate.
Thanks. Next patient is a 17-year-old male, status post fall with a left trimal ankle fracture. He was initially closed reduced, placed into a short Aaos splint. He underwent left ankle RIF.
Can you go back to the last ankle film, or is that down already?
Down already.
Morning. First patient is a 16-year-old male who fell trying to do a layup playing basketball, who sustained his left tibia and fibular shaft fractures. He was closed reduced and placed into a long leg cast that was bivalved. Next patient is a 13-year-old male who fell on a playground and sustained this left distal radius fracture. He was closed reduced and placed into a sugar tongue splint. Next patient is a complicated 86-year-old gentleman who had a supposed seizure, fall from ground level, and had this right acetabulum and bilateral pubic rami fractures that was found the following day after he was admitted in shock. He was brought into the ICU and intubated, and then upon further imaging to look for the source, they found these injuries. CT imaging from the hand scans showed this right acetabulum, anterior column, posterior hemitransverse type pattern. Due to his instability, his underlying dementia that he has, he was made non-weight bearing placed on DVT prophylaxis when stable, and we'll plan for non-operative management.
What was that thing? Was that something behind the patient in the sacrum? Looked like a reamer or something.
I'm sorry, I think it was just like some sort of interference. It wasn't part of him. Oh, you mean his spine surgery? Yeah. Sorry, that was from prior years.
Good morning. First patient's a 5-year-old male, fell off the monkey bars with the left both bone forearm fracture. Was closed, reduced, and placed into a sugar tongue splint. It's a 13-year-old male who is playing soccer and did a slide tackle and has this right Salter-Harris 2 ankle fracture. Was closed, reduced, and placed into a long leg bivalve cast. An 86-year-old female, status was MBC. The left middle third clavicle fracture, also had rib fractures and a pneumothorax. Was placed into a sling. Is a 28-year-old male who was in a motorcycle accident, was flung 30 feet into a tree, and has this right scapular body and left clavicle fracture. He also had liver and splenic lax, was taken for an emergent XLAP, as DAI, multiple spinal fractures with an epidural hematoma, rib fractures and a hemothorax. He's still currently intubated and unexaminable.
The left clavicle, when you see it like that, are you concerned for something? On the just original chest X-ray.
When you see it like distracted like that?
Yeah, or the clavicles when they.
You want to be careful that there's no. You want to be careful that there's no scapulothoracic dissociation.
That exactly. And he needs a motor exam, assuming he wakes up.
Yeah, well, we'll do a careful secondary if he's extubated.
How do you measure for that?
You can go from on the CT chest. You can measure from the spinous processes to the scapular body or the inferior pole of the scapula.
Assuming the contralateral scapula is not fractured.
Right. Good point. This is an 80-year-old female, status post fall, down 30 steps on an escalator, the right anterior shoulder dislocation, coracoid fracture, and left distal clavicle fracture. There was a CAT scan obtained in the ER that better shows the associated coracoid fracture. She was closed, reduced, placed into a sling. This is a 69-year-old male who had to fall in a couple steps and sustained this right proximal humerus fracture. He was seen in clinic and discussion was had about operative fixation. He was taken for a right proximal humerus ORIF.
Why ORIF versus arthroplasty?
We did a delta pec approach. You asked why ORIF versus arthroplasty. Correct. We felt that we would be able to get adequate fixation on the fracture, and we wanted to maximize his, native anatomy. We did talk to him that if for some reason this goes on to AVN and he has issues with it, that the backup would be to go to an arthroplasty.
Are those outcomes equivalent, primary versus secondary?
I don't know the specific differences between primary and secondary, sorry.
How did you control that tuberosity fragment?
The tuberosity is sewed to the plate.
So the results of a secondary arthroplasty are always worse. In fact, not just the shoulder, but every joint than a primary. And so I think the point is well taken, is you really need to decide what you want to do, because operating and then going back later and doing an arthroplasty, the complications are higher and the results are worse if you do it later. But I guess the issue here is that tuberosity was significantly displaced, and in a young person, if you leave it like that, there's a risk of having issues with the shoulder. So I think, was it about 1 centimeter displaced?
Yeah, it was about 1 centimeter displaced, and there was also a split in the greater tuberosity.
So your goal is anatomic reduction and solid fixation, and somehow getting that tuberosity well fixed. And this is not an unreasonable approach if the bone quality is good and you can get a good reduction.
What do you think about the results of
Yeah,
acute versus delayed shoulder replacement, reverse total shoulders? Is there any literature about that?
I'm sorry, I didn't catch that. There was.
What does the literature say about doing a reverse acutely? And is there a time point at which you start to worry that complication rates go up in terms of postoperative dislocation and other issues?
I know that there's been a lot of recent literature for reverses acutely and proximal humerus fractures. That's promising. I don't think there's as much long-term data for that, though, at this point. I don't know what time point specifically.
So a lot of the literature has looked at 4 weeks as a point of whether you're going to decide to do something, do it within 4 weeks.
Dr. Sagebien asked about the approach we took, and we did consider doing a deltoid split, which would have been easier to get to the tuberosity. But in case we need to ever go back to do a secondary replacement, we wanted to have the deltopec. This is a 46-year-old female, status post fall with a right olecranon fracture. She had some comminution, and we elected to do an ORIF with a variable angle plate and then a second 2.0 plate to address the comminution ultimately. It's a 79-year-old female, status post fall, the right distal radius fracture. She was closed reduced and placed into a sugar tongue splint. Is a 73-year-old female with a status post fall with a non-displaced distal radius fracture, placed into a volar splint. Is an 81-year-old female, status post fall with a right hip intertrochanteric fracture, was taken for a right hip intramedullary nail. It's a 76-year-old female, status post fall with a left femoral neck fracture. She has a significant past medical history, subdural, stroke, MI, DVTs on Xarelto, and a history of a GI bleed. She was medically optimized and taken for a left hip hemiarthroplasty.
Good bone.
Yeah, pretty good.
It's a 20-year-old female found outstretched hand with a left radial head fracture. Was treated in a sling, early range of motion, while in the office in 2 weeks. 78-year-old female found outstretched hand with a right distal radius fracture. Was closed reduced, placed in a sugar tongue splint. So a 41-year-old male, he fell 6 feet off a scaffold, a left scapular or clavicle fracture. Was placed in a sling, follow up in 2 weeks. Here's a chest x-ray. It's a 69-year-old female, assessed with mechanical fall 4 days ago with an LC1 pelvis and U-type sacral fracture. Patient has been ambulating with a cane and mild pain since the injury. However, she presented due to persistent pain since the patient had stressed her pelvis over the last 4 days without significant displacement. and no neurologic symptoms. It was decided to treat the patient non-operatively. 16-year-old male, a teammate fell on his wrist while he was playing football with both bone form fracture. His closed reduced and placed in a sugar tongue splint. As a 7-year-old male, I fell off a net at a batting cage with left proximal humerus fracture. Patient was placed in a sling, up in the office. The 31-year-old female assessed with MVA with a PCL avulsion, as well as an AITFL avulsion versus anterior tibial action. Patient had tenderness over the medial and lateral mouth, so a stress view was obtained, which was negative. Patient was placed in a knee immobilizer, but ended up signing out AMA before CAM boot was given. Plan would be treat non-weight bearing for 2 weeks on the left lower extremity, since it may be a high ankle sprain equivalent, and then progress weight bearing after x-rays retained in office. This was a 51-year-old female falling out stretched hand while dancing with bilateral distal radius fractures. Patient was closed reduced and placed in a sugar tongue splint bilaterally.
How are you going to ultimately fix those? Or treat those,
Sorry.
I would say. How are you going to end up treating those wrists?
So bilateral distal radius fractures, and patient who's about 51, I would treat with surgery. Looks like the right one, I think the reduction can be maintained. However, the left one, it looks like not as positive. It looks like it may fail. But however, since it's bilateral and you're going to go to the operating room anyway, I would treat with ORIF bilaterally.
Yeah, you might get some controversy, but I would 100% agree with you. Fix them both.
So let's say I was the one that broke my wrist and I didn't want surgery. Is there anything you could do better with the splints that might give you a better chance of success of maintaining the results? You achieved a nice reduction on both. Is that a preferred position for the wrist? Similar to what you did in the past, you reduced it beautifully and then the wrist is straight. If anything, it's a little dorsiflexed.
So a little bit more wrist flexion.
Well, go back to the injury film. What position is the wrist in? It's dorsiflexed. It's dorsally displaced and the wrist is, and it's angulated dorsally. Wouldn't you want to do the opposite of the injury mechanism?
Yes.
I mean, you got, same with the previous case, you had a beautiful reduction and not, I think you should just bend it down a little, put a mold on it.
Yeah, I'll do it next time.
Did the patient leave the ER?
Yes, yeah. So surgery was offered to the patient, but the patient decided that she wanted to leave, and she had good support at home. So. Yeah. Next one's a 31-year-old male fell off a mountain bike with left index finger metacarpal shaft fracture. Was placed in volar dorsal slabs. The 81-year-old female assessed with mechanical fall with right clavicle fracture, placed in a sling and non-weight bearing right upper extremity. The 7-year-old male found down with a S4-5 fracture and L5 TP fracture. He was nerve acid intact, good rectal tone, and he was made weight bearings tolerated. 88-year-old female assessed with mechanical fall with right distal clavicle fracture, T2 to 6, T8 to 10, 12, and L2 compression fractures, most likely chronic. Patient was placed in a sling, made non-weight bearing to right upper extremity, and weight bearing is tolerated to the left lower. 13-year-old male, he fell off a scooter with a left Goliath fracture. Closed reduction was attempted in the emergency room and placed in a short and bivalve cast. Patient was then taken to the operating room for ORIF with a radius, 3-5 plate, and CRPP of the ulna.
just to clarify, what is a Goliath fracture and what does this patient have?
So a Goliath fracture is a distal 1/3 radial shaft with a DRUJ injury. I guess this would be more of a Goliath variant. It's really a both bone forearm fracture.
Very good.
And how old is the patient?
13. So we got an X-ray of the other side because when we pinned the ulna, we noticed that it looked a little short, but if the ulnar variance is a little negative on the other side, so we thought it was acceptable.
How many years of growth are left on this person?
Don't have a hand film, but at 13 years old, she probably has 2 years of growth left.
Okay. And what was the reason you chose, what kind of plate is this?
It's a 3-5 striker plate.
Oh, okay. It's a striker plate. It looked like it didn't look like a DCP plate.
Yeah. The 20-year-old male, Cesspos MVA with left femoral shaft and left humeral shaft fracture. Patient was placed in proximal tibial traction and a left humerus cuppation splint. The patient's severe subdural and DAI and was not cleared by neurosurgery for about a week. Patient was then taken to the operating room after a week and wasn't able to tolerate lying flat. So the case was rescheduled. And then 2 weeks after the injury, the patient was finally cleared and stable and taken to the operating room for a femoral retrograde IM nail and an RF for the humerus. Of note, the radial nerve was entrapped into the fracture. However, we weren't able to get a good exam preoperatively and postoperatively. For the humeral shaft, 2.0 mod foot plate was used to hold the reduction and then removed after the 3.5 metaphyseal plate was used.
What was your approach?
We went anterolateral.
Can you describe that for us?
Sure. So you make an incision from the coracoid down, or you mark your landmarks, coracoid to lateral condyle. And then you dissect down, you're going to see biceps. You're going to use the interval between biceps and brachialis. Then you're going to see brachialis, you split the brachialis and get down to bone. Musculocutaneous nerves between brachialis and biceps.
So where did you find the radial nerve?
The radial nerve, so the fracture was super displaced that the radial nerve had actually translated anteriorly into the fracture. And so then we were able to extend the incision and dissect it out and then place it back posteriorly and then put the bone over and reduce the bone.
So where do you identify the nerve first?
Oh, where do we identify the nerve? You can go 4 finger breadths above lateral epicondyle. It also is measured to be 14 centimeters above lateral. Yeah.
I know where the nerve is, but when you want to find the nerve and you want to, before you do your dissection, where do you look to find the nerve in order to dissect it towards the area of the fracture?
So you can find it at the where it pierces the lateral intermuscular septum.
So where did we find it before we identified the intermuscular septum? Before we went to the fracture, the first thing we did was we made a big long incision, and the very first thing we did is we looked for the radial nerve. And where did we find the radial nerve? Was it near the fracture, or was it way down below in the very bottom of our incision? Where did we find the radial nerve?
We found it between brachialis and biceps distally. We dissected through down.
Between what two muscles?
It was the extent, the mobile wad and the biceps distally.
No.
What muscle? What nerve is between the brachialis and the biceps?
Musculocutaneous.
Right. So you think the radial nerve is there too? Isn't that more radial and lateral? So it comes around like you said, but you found it distal where it's easy to find, right?
You got it right in the OR when we talked about it. Where did we find the radial nerve?
They all start with B. All the muscles start with B down there, but it's the brachioradialis and brachialis. It's not the biceps. The biceps is 2 anterior medial. So you found it down there because it's the easiest place to find it. And then you followed it proximally to see what's going on. You can't go looking for it when you don't have any idea where it is. You find it where it's easy to find, and then you worked your way proximally, right?
Yeah, I'm sorry. I thought I said brachioradialis. Did I say brachialis?
It's okay.
I'm sorry. That's what I thought I meant.
Right, but the point is, anytime you're looking for a nerve in this type of situation, you always find it where it's easy to find. So it's always away from the injury.
Got it. Thank you.
Any thought about using a 4-5 plate?
You can use a 4-5 plate, show that you can weight bear through the plate. However, he was, not going to move his extremity, so we thought a 3-5 metaphyseal plate fit better. So we decided to use that.
This is, I think this this is a 4-5-3-5 plate, I think, or maybe it is a 3-5. No, I think it's a 4-5-3-5.
It's a 3-5. The 4-5 will have 3-5 screws distally, so they'll be smaller. It's a 3-5 metaphyseal.
Case 14-year-old male was tackled playing football, left femoral shaft fracture. There's no femoral neck. Patient was placed in traction and taken to the operating room the next day for left femur antegrade nail. 6-year-old female got her arm caught going down a slide with a right lateral condyle fracture. Placed in a posterior splint. Taken to the operating room the next day for an elbow CRPP. 2.062 pins were used.
Good morning. First patient, 61-year-old male, status post fall with a right non-displaced femoral neck fracture. He's taken to the operating room for cannulated hip screws. Morning. One polytrauma patient was 58-year-old female. She was pedestrian struck. She was thrown about 20 feet. She presented as a trauma alpha, was awake, was intubated for respiratory distress. From an orthopedic standpoint, she had a right open both bone forearm fracture, which was a focal, but a type 3 by mechanism. She had a right proximal humerus fracture, a right clavicle fracture, a right scapular fracture, a left proximal humerus fracture, and then a left LC3 variant pelvic fracture. She was initially noted to have multiple rib fractures as well, and then had a positive FAST exam. She was taken initially to interventional radiology for embolization. They embolized her left internal iliac as well as her right obturator. And then they also embolized her right circumflex humeral artery, which was noted to be bleeding. She had this right proximal humerus fracture seen here. You can see the coil. These are the x-rays after IR. Left proximal humerus fracture. See on her CAT scan, her clavicle fracture, as well as her bilateral proximal humerus fractures in her scapula. And you can see her pelvis, like a left LC2 and a right LC1. Following interventional radiology, she was stable. About 4 hours later, she was taken that same day for a right radius and ulna IND open reduction internal fixation. She was taken for bilateral anterior column percutaneous screw fixation, as well as a transiliac transsacral screw using a, I believe it was a 1/3 tubular plate, kind of as like a washer. And then we elected to do a right proximal humerus closed reduction and percutaneous pinning because of the, this will be like a staged procedure due to the high chance of avascular necrosis of that humeral head because of the embolization. I think ultimately that'll go on to AVN and will require maybe a hemiarthroplasty. And then on hospital day 2, once she was more stable, we took her back for a left proximal humerus open reduction internal fixation.
Are those pins threaded?
Yes, they're threaded.
And how did you, I'm not sure this arterial injury, how did the arterial injury occur? I mean, it just happened?
So I wasn't present for the attending actually spoke to the interventional radiologist. It sounded like he basically did an angiography of like a lot of the body, and he really wasn't, I don't think he was the most educated individual in what he was exactly embolizing, but was just basically trying to embolize anything that was bleeding, really. And so, there is a certain incidence of, circumflex arterial vessel injury with these fractures. He ended up embolizing it too because there was some arterial extravasation on the right upper extremity. I think there are case reports in the literature of, life-threatening bleeding coming from, circumflex vessel bleeding. I think more commonly, if you have like an axillary artery injury, that's sometimes a little bit more life-threatening. Yeah, that was, those are the vessels he embolized.
It seems so odd that, I mean, people bleed out from that little artery. It doesn't stop bleeding.
So that was the exact discussion I held with the interventional radiologist, who just decided to do angiography on any limb that had a fracture in it. And after talking to him, he said, well, I don't see many of these injuries in the circumflex. So I coiled it because there was extravasation from probably the anterior branch, which probably happens quite often with proximal humerus fractures. So he embolized all of the circumflex. There's actually an IR study, the IR image that he showed me. You could see the brachial artery and all the little runoffs below the fracture and no flow into the head, which I'm sure is not a good prognosis for surviving of her humeral head. But he said, yeah, he hasn't seen or done many of these, and we try to educate him. That's probably because they don't need to be embolized.
Wow. So the posterior circumflex is the posterior.
Everything. That little thing was right. You could see off the brachial a little branch of what would be the posterior, the circumflex, and that's where the coil goes in. And there was no other flow to the head, just everything distally. It was actually, I'm curious if it's in the saved files from IR to take a picture of it.
Well, it would be kind of unusual. I mean, I guess anything can happen, but seems low enough that.
Yeah, I looked in the literature. There was one case report of like life-threatening bleeding from what they said was, a posterior circumflex humeral vessel bleed. And that, I think it was a relatively elderly patient who probably did not have significant reserve. And they ended up just, finding the vessel and tying it off. But, that's the only thing I found.
Are these pins outside the skin?
Yes, they are outside the skin.
I think this is a good idea. I mean, you're giving them some stability, and I don't know. I would obviously wait and see what happens, but
yeah, I mean, she's got significant other injuries. She's got subarachnoid hemorrhage, diffuse axonal injury. So, she's probably not going to be moving or leaving the ICU anytime soon. So we think this was the best option to try to get maybe some healing, maybe get anything to heal if possible. But eventually, I think she'll require a second staged operation.
Well, I mean, you have to think it's going to heal. No, you're worried about AVN. You think this isn't going to heal? I
mean, I think where the fracture is will probably heal, but I think that the head's going to go on to AVN eventually.
All right.
Maybe it could revascularize,
Needed.
Left ankle fracture dislocation. Patient is taken to the OR for left ankle OR. Next patient is a 57-year-old female, status was 4, with left ankle bimal equivalent fracture. Patient was taken to the OR. Next patient is 63-year-old female, status was fall with left mesonephral ankle fracture. Patient was taken to the OR for left knee. OR. Next patient is 30-year-old female, status was fall from wheelchair. She was diagnosed with left proximal humerus fracture, left hip IT fracture, and left C1 pelvis fracture. Patient was taken to the OR for left hip IM nail.
What was she doing in a wheelchair?
So the patient is very sick. So the patient has history of CHF, chronic kidney injury on dialysis, nephrotic syndrome. She's blind, and she's former IV drug abuser. She's in the nursing home. She got history of stroke a couple of years ago due to like blindness, muscle weakness. She was using wheelchair for ambulation for over a year. She was transferring to the wheelchair and she fell.
Is this an isolated injury?
So she got hip fracture and humerus fracture also, and C1 pelvis fracture. So that's the same patient.
Okay.
Next patient is 4-year-old male, status was fall with left type 3 supracondylar humerus fracture. The patient was taken to the OR for left elbow close reduction and percutaneous pinning. Next patient is 81-year-old female, status was unwitnessed fall in the nursing home, who came to the emergency department and was diagnosed with left shoulder dislocation. There was no history from the patient. Patient was nonverbal, severe dementia. So the daughter gave us history. She thinks that the patient sustained injury about a week ago. She couldn't move the arm. She got ecchymosis over proximal humerus, and she was taken to the emergency department for management. We were trying to close reduce the patients. We were not successful. Additionally, during the reduction, we caused the surgical anatomic neck fracture of the proximal humerus. The CAT scan was obtained to find out what's the morphology of the fracture. It turned out that the head is not reduced; it's still subluxated or dislocated. And we discussed with the daughter about the surgical treatment options, but she decided not to proceed with the surgery due to patient status. So immobilized the patients in the sleep. Gave her pain medicine for comfort.
Is it possible that that was dislocated for longer than a week?
It's possible. Yeah, we were we were trying reduction. We were trying with merge technique, but we couldn't abduct the arm above 80 degrees. So we decided to do traction, counter traction technique. She was very tight. She was fighting her muscles. So we're like gently put the traction to get some muscle relaxations. And telling the truth, we didn't feel this fracture during the reduction. We feel that the head was purged over the anterior glenoid, but it couldn't go into the place. Maybe that was because the fracture was chronically dislocated and there was no like opening in the capsule that we could slide in. And finally we caused this proximal humerus fracture.
But it wasn't that chronic. You said you had ecchymosis on the chest wall. And
yeah, she got ecchymosis, but also what we find on CAT scan that she had a chronic rib fracture. So maybe that was not the first fall for the patients. And the patient was nonverbal. She couldn't say anything. She was not even in pain. Like she was grimacing when we deeply palpate the proximal humerus, but she was not like in excruciating pain.
So
And
these people who, when they fall, they get ecchymosis very easily. It could have just been a contusion, and that could have been old. It's hard to know. You know, it's very, very difficult to know. And many times you'll get a chest X-ray, and incidentally, you'll see a shoulder dislocated. And these older people that are inactive and have mental issues, you know, a dislocated shoulder, they function well, and it's not that painful. So I think the learning lesson is just be careful, be gentle, and if it doesn't go easily, just leave it alone and leave it dislocated. It's a little easier dislocated and dislocated and fractured.
Yeah, or more aggressive with your sedation and anesthesia. If you're going to try and reduce it.
Yeah, so the patients was like, she got multiple comorbidities and emergency department. The physician didn't feel comfortable with like, you know, put her in the deep sedation. So the only option was to take the patients to the OR and try reduction. And, you know, she was not very painful, so we inject the joint. There was no hematoma. When we inject, we tried, you know, pull back the blood, but there was no hematoma in the joint. So that was another like warning sign. But even though we like proceed with the reduction, our plan was to gentle reduction, but even gentle reduction was too much for her.
Morning. First patient is a 25-year-old police cadet who sustained this, presented with right hip pain. Was found to have a displaced right femoral neck fracture after doing some combat training. As you can see, this is not the first time she's had this on the contralateral side. In 2020, after doing also in the police academy, sustained this left displaced femoral neck fracture, which underwent ORAF. So we took her to the OR that night for a right femoral neck ORAF.
What caused that? What was the event?
She was doing some sort of combat defensive training and maybe had been kicked. There was no kind of antecedent pain, but that event had been over a week prior to this, presenting symptoms. She had a full workup in her initial presentation for metabolic labs, which were completely negative. This time we also sent repeat labs, again negative. We had endocrine weigh in. They could not find anything. She didn't have any positive findings for the female triad. So we're not exactly sure. She has some very remote family history of Paget's disease, was the only thing that endocrine could find. They're planning on doing a DEXA scan when she's fully healed. But we're talking about remote family history, was like a great uncle with Paget's, maybe had Paget's disease. So she didn't have any other findings.
What implant is that?
It's a Synthes
femoral neck system.
Femoral neck
their
system.
newer implant that has the derotation screw and bolt together. So it combines kind of the DHS and the screw put separately. The other thing that's different is the diameter of the bolt is smaller than the DHS. So it's a little better for younger patients. You're taking a little less bone. And it's also a fixed angle. That's a locking screw. That gives.
You did that open, right?
Yeah, we did an open record.
That was not able to be close reduced?
Just because of her age, we wanted to make sure we had a perfect reduction.
We got it very close, except it was still translated anteriorly. And on the left side, she also needed an open reduction where we used the Watson-Jones and opened the capsule. And so the same thing was done on this side. So she did have the capsule was open, so hematoma was released, although that hasn't been proved to be necessary. And then we were able to reduce it better because she was translated a little bit. That neck was translated anteriorly with just the closed reduction.
Next is a 77-year-old female with a right femoral neck fracture, whose hospital course was complicated by acute cholecystitis, followed by bacteremia, and then later intra-abdominal abscesses. Those abscesses were treated with an IR drain and had been on ertapenem for about 2 weeks. When her white count was finally low enough and the abdominal abscesses were almost resolved, we got the clearance to take her to the operating room for right femoral neck, right hip hemi. We did have an intra-op calcar fracture that was non-displaced, so we did put 2 cables around. Next was a 51-year-old male who's pinned by a forklift, saying this left femoral shaft fracture. Was taken to the OR for a left femur IM now. Next is a 65-year-old female who's involved in MVC with his left distal femur fracture, as well as a non-displaced patella fracture. That scan's better showing the injury, also showing that non-displaced patella fracture, longitudinal split. I was taken for a left distal femur ORF, and we're non-operative patella. Next was a 56-year-old male who's pedestrian struck with his right distal femur fracture. He's taken to the OR for right retrograde femur nail. Next is a 21-year-old male who's playing a pickup football game with some friends, seeing this right tibial shaft fracture. He's taken to the OR for right tibia IM nail. Next is a 16-year-old male who's playing in a high school football game. He's tackled with his left tibial shaft fracture. Initially, he was closed reduced, placed in a splint, taken the following day for a tibial shaft IM nail. Next is a 69-year-old female who is involved in MVC with bilateral tibial plateau fractures, a right distal femur fracture that was non-displaced, a right medial malfracture, and a right proximal humerus fracture. Katt scan better showing the tibial plateau fracture on the right side. She's a chronic pain user and takes 30 milligrams of oxycodone daily. So we took her to the OR for right tibial plateau ORF, as well as a distal femur ORF with cannulated screws.
Is that medial plate going through the fracture?
What the medial plate is, the most distal screw is kind of lagged through that fracture, and then we bridge the fracture with the lateral plate. The fracture does end right at that plate on the medial side. Her left tibial plateau, I mentioned the chronic opioid abuse, was actually found on her secondary survey. Initially, she was not complaining of pain on that side. X-rays obtained showing this mildly depressed tibial plateau fracture. Katt scan was obtained at that time, showing this depressed plateau fracture. I'm sorry, the finals didn't get in, just the fluoros. So she's taken for an ORF with bone grafting. And that medial mal.
What was the indication for fixing that one?
Just polytrauma, trying to get her to at least have some range of motion and mobilization, possibly a little sooner.
How much sooner?
We did discuss non-operative management of that in terms of her being in a knee brace for hopefully up to 3 months.
Did she go back to the OR for this?
She did go back to the OR for this 2 days later.
And the indication is, you said earlier range of motion?
Their range of motion and not likely, but potentially earlier weight bearing.
How are you going to earlier weight bear her with the more messed up a contralateral limb?
I mean, she's gonna be bilateral non-weight bearing for a better part of 2 months.
I don't think that's gonna improve your range of motion either. I don't expect them to accelerate that at all.
Unlikely.
Here's the medial mal, minimally displaced. Took her for medial mal ORF, and then the proximal humerus.
Is that for earlier range of motion as well, or weight bearing?
This was initially taken at the same time as the left side.
Okay.
With her concomitant injuries. The idea was to try to get her good range of motion in the ankle and earlier weight bearing through the ankle, but we're not going to be able to weight bear her sooner because of the knee. And then the right proximal humerus, which we decided to treat non-operatively since she's not weight bearing.
Sounds like you could have probably treated all of those non-operatively, except for the right.
Yep.